Hello, everyone. Welcome to the Zoom meeting. I'm going to just share the agenda with you.
Okay, otherwise I will.
And then,
okay.
So we're going to talk about three different topics: frailty, how to calculate sample size in the research project, and then SPSS.
Right.
Go ahead when you are ready, Dr. Shumaila.
Okay, I'll share my screen. I'm sharing. Okay.
Yes.
Okay.
Yes. Thank you.
So can you see my screen?
Yes.
Okay. So this is the topic. I and Dr. Shumaila Zafar, we prepared this topic: frailty in healthcare, understanding and assessment and management.
Okay, Olivia, it is not coming like again in the full screen. So is anyone there? Because my computer doesn't share. Is anyone there who can share the screen for us? It will be a help.
I don't know how to make it big because the last time I tried, but I couldn't do it. So someone else share the screen. I already shared this PPT in the group, 9th May.
So
Who is that?
maybe, Dr. Olivia, maybe what you can do is you can follow these steps. So step one, just hear me. You're gonna take unshare the screen. Step two,
Unshare.
you're gonna share the screen.
Okay.
But
share the,
you already
share.
opened when you share the screen, there is options. One of them is the whole window of the computer or the whole screen. Do you have that?
If you follow Dr.
It's called
Nadir
application
instructions.
window or entire screen.
Wide window iPhone. I don't know how to. Okay, I did it. So I don't know. Whole window. I don't understand what does it mean. I'm not able to do it. In my, I don't know. I'm trying, but it's not coming. When I starting, it's coming like that. How to do it? Is anybody there who can share from their laptop?
Let me see if I can do it. Okay, let me try. Is it okay? Everyone can see?
Oh, yeah. Yes, it's better. Right? I can see. Okay.
But
Okay.
it is coming like that only. How your screen
Yes, same. It's coming in my laptop also. I don't know how to, remove this left side port part.
1 minute. No, there is. It doesn't share anything else. It come only like that.
Yeah, from my laptop also, it's coming like that. I don't know.
Okay, let me send it to Dr. Nadir.
Okay.
So it's in the main telegeratic group now. Or
Okay.
WhatsApp group.
I'll be back with you in a second. I have to answer a phone call.
Sure. We need to change the settings or do something. Hmm. Just to make sure 2 p.m. still an hour later. No.
So you send it by email
You want me to
or the chat,
in that main TGRF group, WhatsApp group.
WhatsApp group? Okay. I'm not in the group, so sorry about that. Can you share it in the chat here, maybe?
One.
In the email, sir, right?
Huh.
The email, okay.
Okay. Okay, I didn't know that you are not there. Okay, wait, just give me 1 second. So, Shumaila, can you do this thing quickly? From India, it will take time to open.
Nothing is working over here. They're saying you need to activate the Microsoft 365.
Okay, can
That's
you give
okay.
me
Why
some?
don't Olivia, Dr.
Yeah.
Olivia, just share it, the screen, the first one you did. Go ahead,
Okay.
share that screen. Yeah.
Okay. Can you see my screen?
Yes.
Okay, wait. It will go. Okay, so today's topic is frailty in healthcare, understanding, assessment, and management.
Hmm.
So what is frailty? So frailty is a clinical syndrome common in elderly. So patient presented with weakness, weight loss, low activity, and increased vulnerability. So bottom line is it reduces the body strength and higher risk of a health problem, even with the minor stress. So we can see in the picture, frailty is a clinical syndrome, as we discussed earlier, commonly seen in the elderly individual, presented with the weakness, reduced physiological reserve. As a result, even the minor illness or stress lead to serious health complications. So what is the clinical significance of frailty? So patient, there is a chance of falls, frequent hospitalization, disabilities, and dependency, higher mortality risk, and reduce the quality of life. Even with the minor illness, patient may have serious complication in frail patient because their body has reduced reserve capacity. In this picture, we can see in 1990, there is only 0.5 billion patients presented with the frailty, whereas in 2010, it increased 4 times more, that is 2.0 billion. And in 2040, it's going to be 3.5 billion, and 2080, it will go up to 4.5 billion. So the graph shows the rapid growth of the aging population worldwide over the years. Elderly population increases, conditions like frailty are becoming a major healthcare challenges. So here is the chart where we can see there's a frailty progresses through the self-propagated cycle that gradually worsen physical function and independency. In frailty, we can see there's an acute health crisis it leads, and therefore standard care we need it. And if the patient is not able to in complete recovery, if suppose, then it again leads to the frailty. So this is the flow chart where we can say that frailty can lead to weight loss, muscle weakness, reduce the physical activity, decrease the mobility and endurance, dependency, and functional decline. And that all leads to further weight loss. And this creates a continuous cycle. Here in this chart, you can see there is a patient mostly in Frailty having caloric malnutrition, and that lead to weight loss. So we need to, what we can do when patient have coming with weight loss, we can give the medical replacement and energy supplementation. And when the patient having weight loss, it leads to sarcopenia. That means the muscle mass is reduced. So we can give the protein supplementation such as L-carnitine, leucine, mixed amino acid. And in that, when patient having decreased physical activity, that leads to decreased muscle mass, as we said before. Protein supplementation, amino acid, EPA, DHA, and the vitamin D we can give. And disability and dependency, that causes the caloric malnutrition. So medicines replacement, we can meal replacement, energy supplement, and Mediterranean diet we can give to the patient. So this vicious cycle goes on, but if we want to prevent it, we have to follow these steps. So difference between Frailty and normal aging. So normal aging, there's a gradual decline in normal person, whereas Frailty, there's an accelerating decline. Their aging, and they normal aging patient are independent, but Frailty, they are very vulnerable. Their normal day-to-day activities goes on, so they have a stable function, whereas here the reserve reduce. So normal aging involves the gradual physiological changes over the time. Frailty is a pathological condition that decreases the resilience and increase the vulnerability. So frail patient individuals are at higher risk of falls, as we discussed earlier, hospitalization, and they become dependent on others. So understanding of a frailty and disability along with the comorbidity. Frailty, as we said, is a reduced physiological reserve, increase the vulnerability to stressor. Disability means difficult to performing daily activities and their loss of the function independence. Comorbidities when they have already multiple chronic disease, which commonly seen in the aging population. Here is the picture where the frailty is associated with the multimorbidity and disability. So the diagram shows that overlap between frailty, disability, and multimorbidity in elderly patient. So although they have an interconnected frail patient, but this is a distinct clinical condition that is increased with the vulnerability. So pathophysiology mechanism of the frailty. So frailty results from progressive decline across multiple physiological symptoms that leads to reduce the resilience and increase the vulnerability to stressor. So as we discussed in the picture, the sarcopenia, as we know, their age patient, elderly patient having age-related loss of skeleton muscle mass strength, but here they are reducing too much. Contribution to the weakness, poor morbidity, and falls. Chronic inflammation because persistent low-grade inflammatory state in the aging population, and acceleration tissue damage and functional decline. Hormone dysregulation because there's a reduced level of anabolic hormone, and that leads to the impair the muscle maintenance and energy balance. Immune dysfunction is disrupted in elderly people, so increased susceptible to the infection and delayed recovery. So frailty developed due to the interconnected biological change occurring during aging. Among these mechanisms, sarcopenia plays a major role by reducing the muscle strength and physical function. Here is the picture where we can say the healthy muscles mass, healthy skin, fatty tissues, bone marrow size, and the bones. But when the patient having sarcopenia, we can see the muscles mass is reduced, and the healthy skin is and the difference between the fatty tissue and the healthy skin has been increased, and bone marrow size, however, remains same, but the bone size is increased. here in 30-year difference between the muscles mass in the 30 years, 50 years, and the 80 years. So this image tells us the sarcopenia that refers to progressive loss of muscles mass and strength with aging. Sarcopenia is, as we said earlier, the major biological mechanism that contribute to the frailty, weakness, and reduce the morbidity in the older patient, adult. Here we can see in the picture the differentiate with the healthy person, the muscles mass, and here in the sarcopenia. So we can see the bone mass and bone, muscles, and fatty tissue, and the bone marrow. In sarcopenia patient, here the fatty tissue size is increased as compared to the muscles mass. Muscle mass is reduced. So major demonstrate of the frailty is advanced age, progressive physiological decline associated with the aging, increase the vulnerability and reduce the functional reserve. And patient having chronic disease such as diabetes, cardiovascular disease, arthritis, this also contribute to physical deterioration. Cognitive dysfunction decline, impaired to the cognition, affect mobility, independence, and overall health outcome. Malnutrition, inadequate nutrition intake accelerate muscle wasting and weakness. Frailty is the multifactorial and result from interaction of physical, psychological, and social factors. Here is the picture where they are discussing about the most common disease we can see in the elderly people. So brain disease are common, gout we can see in elderly people, diabetes, ischemic heart disease, arthritis, and the eye disease. Here in the picture, we can see the patient with the frailty patient, they have a decline in cognitive function that also impair the mobility and reduce the independency and negative effect overall health and daily functioning. Here in this picture, the malnutrition affect 1 in 10 older adult in the community. So older of 85% of older adult in UK study, they said is failed in consume the ESPN and recommended protein intake 1.2 grams per day. So low protein associated with the increased frailty in older adult. So that leads to reduce the muscle strength, increase the risk of fall, impair the wound healing and recovery, and it takes long time recovery from the surgery. Impair the immune response and recovery from the illness and proper clinical outcome and higher mortality rate. So increasing the risk of frailty and sarcopenia, malnutrition threats, independence in the daily life. So lifestyle and environmental detriment of the frailty is first is physical inactivity. We, as discussed earlier, reduce the physical activity leads to muscle weakness, decrease the endurance and impair mobility, social isolation. Limited social interaction that leads to depression, reduce the support and functional decline. Poverty, poor socioeconomic condition also affect the nutrition, healthcare access, and overall well-being. Polypharmacy, as elderly people, they are mostly having multi medication, taking increased risk of adverse drug effect, falls, and frailty progression. So, and bottom line is that the environmental and the lifestyle factor plays a major role in accelerating frailty among the older people. Clinical indicator of the frailty. So unintentional weight loss, significant loss of body weight due to the reduced nutritional intake and muscle wasting, weak grip strength, reduce the muscle strength, indicating the decline in the physical function and endurance, slow gait speed, decrease the walking speed associated with impaired mobility and increased risk of fall. So these clinical signs an early indicator of decline physiological reserve in older people. So in this picture, we can see frailty symptom that could indicate you have a frailty include. So first, often fatigue, or they feel like overexhausted, losing the weight without trying, and balance and the stability issue. They are not, they're having the gait issue. So elderly people, they are having leaking pee and poop by accident, social isolation, and that leads to depression. So moving slowly or having other trouble moving around. So needing help with the activities of daily living, like feeding, dressing, or bathing yourself, can reduce the frailty. Importance of an early frailty assessment. So this is the bar graph that shows the improvement with the early intervention. So outcome is a patient having fall, so they are without early detection, so they have very risk of falls without early detection. But with early detection, falls incidence reduce. Suppose patient, the hospitalization is more frequently seen if patient is if without early detection, whereas in with early detection, hospitalization is reduced. So quality of life improved with early detection, but in uh, early detection, but without early detection, they have a poor quality of life. So prevent function decline and complication, reduces the hospitalization and healthcare burden. That improves the independence and the quality of life and enable the timely multidisciplinary. So we need a multidisciplinary intervention to prevent the frailty. So from here, Dr. Shumaila, you can continue.
Okay.
Can you
Thank
see
you.
my screen?
Yes. So thank you. So common
Hello?
screening tool. I'm here. I'm here. So common screening. Now we talk about the frailty a lot. Now, what are the screening tool for the frailty assessments? So Edmonton Frail, there are the three scales actually. So one is the Edmonton Frail scale, a multi-dimensional tool assessing the cognition, mobility, nutrition, mood, and the functional performances there. The second tool is Tilburg Frailty Indicator. It will evaluate the physical, psychological, and social component of frailty in the older adult. The third one is the Prisma 7. Hello?
Can you hear me? Can you see my screen? Can I
Yes.
share? Can I share my
Yes.
screen? Can I share my
Yes.
screen one more time? Okay, let me share. Can you see?
Yes.
Okay, now you
Can you hear? Okay. Can you hear me?
Yeah, clearly.
Okay.
Go ahead.
So there are the common screening tools for the frailty assessment is there. Now there are the there are the three scales actually. One is the Edmonton Frail scale is there. That is the multi-dimensional tool assessing the cognition, mobility, nutrition, mood, and the functional performances there. The second one is the Tilburg Frailty Indicator, which will evaluate the physical, psychological, and the social component of frailty in the older adult. And the third one is the Prisma 7, a simple questionnaire used for the rapid screening of frailty risk in elderly individuals. Frailty assessment tools support the early detection and guide appropriate clinical intervention. So next.
Yes.
So there is the two criteria right now we have. So one is the Fright criteria, in which we will check the 5-meter gait speed test, hand grip strength test, physical activity questionnaire, CESD questionnaire, weight loss, and sarcopenia. Each item is scored 0 to 1. Frail if composite score is more than 3 by 5. The other criteria, that is the Frail criteria. What we have to ask to the patient, right? Fatigue. How much time during the previous 4 weeks did you feel tired? All the time, most of the time, 1 point each. Resistance. Do you have any difficulty walking up 10 steps alone without resting or without aid? If yes, 1 point. Ambulation. Do you have any difficulty walking several hundred years alone without aid? Yes, 1 point. Illness. How many illness do you have out of the list of 11 total? 5 or more, 1 point. Loss of the weight. Have you had the weight loss of 5% or more? Yes, there is a 1 point. So Frail score range from 0 to 5, 1 point for each component, 0 best to 0 best to, and 5 is the worst. Robust 0 point, pre-frail 0 to 1 point, and the frail is 3.3 to 5 points. Next.
Yes.
So now we are assessing the frailty. How we will be assessing, right? So when we are doing something, physical performances we are doing, so we will check the gait speed, grip strength, and sit to stand test. Now there is the physical frailty. Frailty phenotype is there. Frailty index, that is CSHA frailty index, we will check, and the electronic frailty index is there. Multi-dimensional tool, that is the fact, and the Edmonton Frail scale is there. And then we will do the comprehensive geriatric assessment is there, CGA method. So several validated tools are available for screening and assessing the frailty in the clinical practices. These instruments help healthcare professionals identify high-risk elderly patient and plan appropriate management. Next. Clinical consequences of frailty. What will happen? There is a frailty. So fall and fracture. There will be the increased muscle weakness and the balances will be poor, which will increase the risk of the fall and injury. There will be the frequent hospitalization because of the frailty increases the vulnerability of illness, leading to the frequent hospitalization. And this costs a lot actually. In our US health system, there is the frequent hospitalization or readmission of the hospitalization. It will cost 26 billion. When I was doing the rotation with one of the doctor, so he told that it cost 26 billion. So functional disability, that is the progressive decline in the mobility, and the daily activity reduces the independence. There is the increased mortality risk. Several frailty is associated with the high morbidity and mortality in the older adult. Frailty significantly affect the physical health, functional ability, and the overall survival. So here is a picture. Image show the emotional and psychological burden experienced by many frail older adults. Frailty can lead to the stress, dependency, reduced ability to manage the daily activities independently. So this again picture, this highlight the importance of the supportive care and assistance in managing frailty among the older adults. Compassionate caregiving and the multidisciplinary supports can help improve quality of life and maintain the independence. So multidisciplinary approach to the frailty management. Now what we have to do? So comprehensive frailty care requires the collaborative management. Frailty affect the multiple aspect of the health. Therefore, effective management requires the coordinated care from the different healthcare professionals. Physician, nurses, dietitian, and physiotherapist. Everyone has to be involved in this. Physician they will diagnose and manage the chronic medical condition. They will review the medication and monitor the overall health status. Nurses, they will monitor the daily health needs and the patient safety. They will provide the patient education and the supportive care is there. Dietitian, they will assess the nutrition status is there, recommend the protein-rich diet and nutrition supplementation is there. Physiotherapist, that improve the muscle strength, balance and mobility, reduce the fall risk through the rehabilitation exercises. Next. So here, we have to form a multidisciplinary team, right? So mental health, social work will be involved, social care, multidisciplinary team, admin will be involved, visiting geriatricians that will prevent and do the assessment to the team, wider community services. So that will also a combination of the multidisciplinary team coordinator and the community psychiatric nurse. Then every single person is involved and it will form a multidisciplinary team and will help to overcome the frailty in this patient. Now something regarding to the nutrition. So when we have to do the exercises can be of different types. So one is the resistance exercise, that will be the moderate to high intensity. That can be the power training, aerobic activities, flexibility training, and balance exercises. Then the diabetic care, individual hemoglobin A1C, glucose, and the continued glucose monitoring targets. Simplified insulin regimen based on the frailty. Severity to reduce the hypoglycemic risk. Use of the diabetic technology, continuous glucose monitoring, hybrid closed loop systems when appropriate and feasible. Nutrition, adequate protein intake, micronutrition repletion, vitamin D, prevention and the treatment of the weight loss and cachexia. Comorbidity management. Optimal management of the complications and concomitant conditions, cognitive impairment, depression, and sarcopenia has to be dealt comprehensive geriatric assessment to identify and intervene on the reversible contributor. That's why when our parents are older, so we need to take care of them a lot. So clinical case scenario, frailty in the older adult. 75-year-old female with a history of type 2 diabetes mellitus, poor nutrition status, reduced the physical activity. She presented with the progressive weakness, slow walking speeds, and recurrent fall over the past few months. Now, what are the clinical findings patient demonstrate? The patient has the unintentional weight loss, reduced mobility and balance, persistence fatigue and low endurance, and there is the dependence in the activities of daily living. Clinical interpretation, these findings are suggestive of frailty with a functional decline and increased vulnerability to the adverse health outcome. Frailty often develops due to the combined effect of aging, chronic illness, malnutrition, and the reduced physical activity. So again, there is a beautiful picture. It shows that the typically clinical scenario of frailty in an older adult required the mobility assistant and a multidisciplinary team. Frailty often affect the physical function, balance, independence, increasing the need for the supportive healthcare intervention. Nutrition support in the frailty management. We have to provide the patient to the high protein diet. It will support the muscle maintenance and improve the strength. Vitamin D supplementation, they will help maintain the bones and the physical function. Hydrate the support, prevent the dehydration, and improve the overall physiological function. Adequate nutrition play an important role in preventing the muscle loss and the functional decline. So, exercise and rehabilitation in the frailty management. As we already discussed, there are different type of exercises. Resistance training, that will help improve the muscle strength, endurance, and the physical performance in the older adult. Then there is the balance exercise. It will reduce the risk of the fall and improve the postural stability and coordination. Mobility improvement enhances the walking ability, independence, and overall function capacity. Regular physical activity and rehabilitation are essential for maintaining the strength, mobility, and independence in the frail older adults. So here, woman is beautiful picture showing she's doing the strengthening exercise. So medical and the supportive management of the frailty. So management, they are based on three criteria basically. So if there is the underlying disease, like the patient has the diabetes, hypertension, cardiovascular disease, help reduce the frailty progression if you control them. So medication review, regular assessment of medication help prevent the polypharmacy. So adverse drug reaction and the risk for to avoid the polypharmacy, the pharmacy has to be involved. Now the mental health support, psychological support, and the counseling improve the emotional well-being, social participation, and the quality of the life is there. Comprehensive supportive care help maintain the functional independence and improve the overall patient outcome. It's a beautiful picture again that frailty management should address both the medical and psychological aspect of the health is there. Supportive care improve the overall well-being and help maintain the independence in the older adults. So what are the prevention strategies for the frailty? So there are the 4 strategies basically. Healthcare lifestyle. We have to provide the balanced nutrition, adequate sleep, and the healthy habits help maintain overall health and the functional capacity. Early screening, timely identification of frailty risk, allow early intervention and prevention of the complication. Regular physical exercise provide the strength, balance, mobility while reducing the frailty progression. Social engagement, social interaction, and community participation improves the mental and the emotional well-being. In the USA, while we are working, we are going out, we are working. So there are the special center like daycare for the older people are meant. They sit there, they chit chat. So by that way, they are taken care. So frailty prevention focus on focus on maintaining the physical, psychological, and the social health throughout the age. So avoid frailty. So it's a mnemonic. We have to do activity. We have to vaccinate properly. The patient has to be vaccinated for the flu every year, above 65 pneumonia for 5 years, shingles. So they have to be taken care like that. Optimize the meds. Interact like social interaction, diet and nutrition. By that, we can avoid the frailty somehow. Now, what are the conclusions? Frailty is a significant geriatric syndrome associated with the reduced physiological reserves and increased vulnerability. Early identification and timely intervention can reduce the complication and improve the quality of life. Multidisciplinary management, proper nutrition, exercise, and the supportive care are essential component of frailty care. Frailty is not an inevitable part of the aging. With the appropriate interaction, healthy and independent aging can be promoted. So, what is the active aging? The patient should be having, first of all, mental well being, social engagement, economy security, lifelong learning, preventive health care, community involvement, accessible infrastructure, combating ageism, cultural participations, legal protections, empowerment, and the physical health. All these good points will make an active aging. Frailty is growing healthcare concern in aging population, but it is manageable with the early and comprehensive care. Promoting the healthy aging can help older adults maintain the independence and improve the overall quality of life. Thank you so much.
Thank you, Shumaila.
You're welcome.
Thank you both, Shumaila and Olivia, for great presentation. I
Thank
think
you,
this
Dr.
is an important topic. Yeah,
Thank
it's very important topic, and people should know some about this. And we can apply to our family members who are older, like if you have parents, grandparents, or any elder family member, you can
Right.
also just think about it and maybe
You're right,
fix.
absolutely right. Of course, our
Yeah.
elder parents.
Yeah, if anyone wants to share their prospect or any experience or any thing in life that apply to this, please go ahead. Thank you.
I can say about my father, he's a doctor and he's very particular for his diet and everything. And I used to keep saying that, Papa, you are losing your weight. So once he got sick, like he got infection through the nose, like cellulitis on his face. So he was not able to eat too much. So that is a frailty. Then he said to me that, yes, I was very conscious for food, but I said, I wish you could have eaten, a proper amount of food. You were not eating proper non-veg, proper protein, and now you reduce your weight a lot. So that is what I have noticed yesterday.
Hello?
Yes, Shumaila. Next, who is going to present topic?
Yeah, sorry, it's gonna be me. I'm topic number 2. Apologies for the delay because I had a technical issue as well. So the timing. Anyways, thank you, Dr. Olivia, for sharing that with us. How is your father now in regards to that?
Yeah, he's getting better with his antibiotic.
Yeah, I actually might have a story to share about which shows us as to why this topic is such a relevant topic, specifically with the elderlies. My great grandmother, she managed to reach until the age of 94, I'm assuming, or 95, something like that. So what happened was that she was still able to walk and she was still very active. But what happened was she wasn't really active with exercising. So the bones are brittle. And so what happened was she slipped in the kitchen and it caused her hip to break or her leg. I'm not particularly sure because I was a bit young. So what happened was she had to go through an amputation, and this caused her like very, very severe depression, and which actually caused her death because like you know how like the mental stress could get into the elderly, and which shows you why like we should genuinely like support the elder population and tell them the relevance of exercising and genuinely keeping you know themselves healthy and the body. So you see, like as here, like an example to my great grandmother, like I hope she's resting in peace now. um you know, it shows you that such a small thing, or what we see as something small, like happened to impact her to the point that actually like cost her like a great depression, which led to her death. So this is why we should be like, actually we should be very, what do you call it, proactive with this topic, specifically with informing the elders. So yeah, that's on my topic. That's on my thing to share.
Yeah, even I have a personal thing to do. Can you hear me?
Yes, I can. Yes, doctor.
Okay. So my mother, like on March, it was like 13th or 15th, 14th Ramadan. So she fell again in the kitchen. The same thing happened. And she got 4 fracture in her right foot. So 2 surgeries. We have to be gone through. All my Ramadan was in hospital, going back and forth. And this is my third month, basically. So when this thing happens, she's not too old, like she was 65 plus, but the family also suffer a lot. I'm the only daughter. I have to manage everything. I
Yeah,
have to work. I have to do
yeah.
rotations, so everything is very late, getting late. I cannot go out and do the
I hope she's
rotations.
well now.
She's well now. Alhamdulillah,
Yeah, I
alhamdulillah.
hope she's well now.
Yeah, yeah,
Alhamdulillah, alhamdulillah.
yeah. So 2 surgery
Is
has
she
done.
doing
So
physical therapy
yeah,
or?
she's going for the physical therapy. Everything is good now.
Yes, that's good.
So,
That's great. That's
the
great
stitches
news.
has removed. Yeah.
Yeah, that's great news.
So it's a very fragile topic and very important that we have to take care of elderly.
Important. Yeah.
So very important.
Yeah. Exactly.
Shumaila,
So thank
very,
you so
very
much for
well.
informing us.
So
Thank you
I
so
have
much.
something to share.
Go on.
Yeah. So recently, that was in December 2025, my aunt, who's like my mother's older sister, she was around 74 years of age, and she had huge medical history to present with. Like she was known hypertensive. She was diabetic since 35 years of age, and she was known history of CAD and history of stroke, and she had all the conditions which we just discussed. And recently in December, she had UTI. We thought she would, get better with antibiotics, but eventually that led to, renal failure. And even before, as they just started dialysis, she went through a lot. And now I feel, I mean, when we went through every step of the frailty, now I feel how important it is to address. We just think it is old age, but how important it is to manage this condition. With all this polypharm, she had a lot of, she landed up in heart failure. I mean, like she had just a lot of medical conditions that she was being going through, and I feel, she could have handled it a little better with, support of family and all that.
I'm so sorry, Rupa.
Yeah, we lost her in December, but I mean, everything that you guys were discussing, I could just relate to what she underwent. So yes, I think even as doctors, when we see geriatric age group patients, I think we need to counsel them, strengthen them. I know it would be difficult, but we can do our part. Yeah, that's what I want to share.
When I was presenting this topic, I just came to know on Monday, and
Okay.
suddenly my papa got sick on like 2 days before. So when
Oh,
I'm doing all
I'm
the
so
means
sorry.
before that, my father was completely fine, and two
Okay.
days before he was getting sicker, and yesterday he was gravely
Oh,
sick. I can't tell you.
really?
While reading all this presentation, I was correlating with my father condition. And I was
I'm so
thinking,
sorry,
we are
Olivia. Yeah,
thankful to God that my brother, and everyone was with him. But
Okay.
it was very tough. Who doesn't have family back support? Then it is very
True.
tough.
True. And that to being our parents, it takes it I can totally understand. Yeah. I can totally relate. Yeah. I'm sorry for that. I
Thank
hope
you, thank you, thank
I
you so
hope
much.
he gets better soon. Yeah.
Thank you so much. Thank you, Rupa. Thank you.
Yeah. Thank you so much. Yeah.
Yes, thank you so much for being able to share such stories. We're able to put not only like the theoretical part, but also the empathetic part, like being able to actually, like almost experience or like to put ourselves in the shoes of others is a beautiful thing, I guess. So thank you so much for everyone's story. And if anyone doesn't want to share anything, I guess I'll proceed to my presentation. And thank you again. So, okay, so I guess I proceed. Uh,
Go ahead.
okay, is my screen good like this? Can the
Yes.
people see? Okay, thank you. Okay, so good evening. So today we're actually going to talk about a highly relevant topic in research, but a misunderstood one, which is sample size. So today, hopefully, we get to tackle it together. So, what is sample size? So, sample size simply refers to the specific number of individual or participants that you include in a study. So it's basically just the population that you include in a study. So can anyone tell me why is sample size important? Like why is it relevant? Why can't we just take the population of everyone? Or, does anybody know or would anyone like to share? Okay. So the reason that sample size is important, it's because so you could just say that, oh, we want to take a we want to take like per se, like there's a population of hypertension. So say that you want to see India, for example. So you have to take the entire population of India and everyone that has hypertension. That sorry. Oh, sorry, Dr. Almar, I might have interrupted you. Well, were you gonna say something?
Can you hear me?
Oh yes. So sorry. I didn't see you there.
Y- Yeah, so sorry. I just thought I would answer your question. Why is
Yes,
sample size
thank you.
important? Yes, so sample size is important because when we have a larger sample size, it increases the power of the study. So it makes it easier for us to like see the real effect or the difference. Small ones, they often like not give us accurate results, or it might give us false negatives, and also to reduce the margin of error because we need to have a bigger sample size in order for us to decrease the margin of error to make it more, to provide a more precise estimate of the true population. So, yeah.
So in your opinion, why do we just take a sample size instead of actually taking like just the population in itself, the entirety of a population? Like, why don't we do it as a scientific like researcher? Do you have any idea? Hello, Dr. Almar, if you're still here.
Can you hear me? I'm so sorry.
Yeah, you had your mic muted. Yeah, it's okay.
Sorry about that. Can you hear me now?
Yes.
Yes. So, can you repeat your question, please?
So, like, as a researcher, like, why don't we just take the entire population of, let's say, India, if we want to see like people with hypertension? Why don't we just take the entirety of India, the entirety of the patients in India, as like, and we just do a research on them rather than just taking a sample size, like a small sample size.
It's important to be very specific and accurate in your research. So if we're going to take a large, like a big, large sample size, that's also not going to be good for accurate results. So we want to be as accurate as we can for a particular population to represent a particular area. And that's the whole point of research, for it to be very specific and particular.
Yes, thank you so much. So exactly, this is exactly what I wanted. So like why sample size matters, we have accuracy. So as Dr. Almar said, like we want something to reflect the population. Not only that, it's also really costly. Like if we did a research on the entirety of the people who have hypertension in India, it would take a lot of money. And so we just want a reflection of the population, not the entirety of the population, just because the cost as well. You have to think about the money as well sometimes, you know? It's still an industry. Okay. And as well as validity, as you said, which is absolutely correct. We want to avoid false negative as much as possible. Thank you so much, Dr. Almar, for your participation. So what are the parameters of sample size? So for the sample size, what truly matters for a sample size, like if we're going to get a sample size, you need to have the population size, right? So you want the number of say like number of people who have hypertension in, let's say, either Sudan, Saudi Arabia, to do an actual research on that. The confidence level. So how sure are you that after like you give them a number per se, like, oh, this is the mean of blood of the mean and the blood pressure in India, how sure are you that this number, if we repeated it in another research, it's going to appear as the same number that you just gave them? So usually we stick with the number of 95%. So we're that confident with our research that if someone were to do this research again, they're gonna have almost the same exact number, say +2 or -2. So it's either 9. So say that the mean systolic blood pressure in India would be, let's say 120. So in our research, we wrote 120. So it's going to range between 120 plus or -2, which means 120 to 122 or 122 or 118 to 120. I don't know if that makes sense. I'm so sorry because I'm unable to show. Am I able to show you guys because I'm using my phone because my laptop is simply not working. So sorry. So apologies for that. And then we also have the margin of error. So the margin of error is like you give yourself, like as it said here, the amount of wiggle that is allowed. So let's say the amount of room for you to make a mistake. So we usually put it at 5%. So the more that you decrease the room for error, the more sample size you would need. Why is that? Does anyone know? So if we wanted a number to be, if we wanted our research to be very precise, let's say that we put the margin of error as 1%, we'd have to increase the sample size, which then again would not be as good for like as good. It wouldn't be as good for it. It would be really costly, and it would take a lot of effort. So in the scientific community, we allow for a space to commit like errors. So let's say like so in this just I guess like we usually put like 5% of the as the amount for as the room for error. And then we have the standard deviation. So here we usually put 0.5 as a conservative estimate. All right. So the balancing act. So this is what I mentioned earlier. If we wanted a research to be very precise, we'd have to move the margin of error from 5% to 1%, which means that we have to double our sample size. So for example, we have a sample size of 355. So if we decrease the margin of error, it's going to be 9,000. I'm so sorry, I'm unable to actually show this, but wait, I guess like there's a way that I can show you in Google. So here we have two essential formulas for sample size. So how do we take this formula? So we use Cochrane's formula. This is when you have an infinite population where the number of the population is actually unknown. So let's take an example. Actually, I can give you guys like a calculator. So we can nowadays there's actually a calculator to calculate the sample size for you. So say that you want to make a research, right? And you want the sample size to have a 95% level of confidence with a 5% error, 5% error, margin of error, and usually the population portion. If we're not usually sure about the population portion, we usually put 50%. So these are going to be available in the calculator, but you usually put the 50% if you're usually not sure. And the population size, so we can leave this blank. So this is exactly what Cochrane was mentioning. This is where you use the Cochrane's formula. So here on an actual sample size calculator, you can simply just click this, right? So this one you will have Cochrane's. So Cochrane tells you that you need a sample size of 385. This is already a computer-based answer. So if you're not sure of a population, you can either use a manual formula, which is Cochrane formula, or you can simply go to Google and search up a sample size calculator. And we usually give you a sample size of 385, specifically if your population size is usually unknown. Now, let's say you have Yamein's formula. So when do we use Yamein's formula? Yamein's formula is usually for finite population, in which you actually have a population in mind, and you can actually put it. Let's say in a coffee shop, you wanted to determine something in a coffee shop, like the amount of coffee or the population or the amount of customers in the coffee. Let's say that there's 1,000 people going to that coffee shop, right? So right now, since I have the value or I have the exact population, I can write this down here. So my population size is 1,000. Let's go. So here you have a sample size of 278. So the good thing with modern technology is that you can actually just go to Google and search up for a calculator, and it's up to you, depending on you and your research group, as to whatever confidence level or the margin of error, and all the other things is upon you guys to agree. But the sample size, the heart of the sample size remains the same. So the difference between these two formulas is, one is if you don't have a population size, right? You don't know. Example, let's say India, right? The population is wide and like big, or let's say Saudi Arabia. You're not entirely sure about the formula, right? So you can usually just either use Cochrane or just use this sample size calculator, which then again, as I mentioned, you can just leave it blank if you don't have a particular, and then it will give you the exact same number. So you also have Yamein, as just to reiterate the information, Yamein is when you have a finite population where you already know the number. So for statistical power, as Dr. Almar mentioned earlier, we need a good sample size to be able to have a really good and an accurate research, right? So we usually aim for 0.8 power, right? So when the sample size grows, the power will also increase, as you can see here. So when you have a smaller sample size, your power is lower. Okay, so here's the margin of error, right? So this thing is just explaining. So basically you have the margin of error here. As you can see, as I've explained earlier, the margin of error, when we decrease the margin of error, look at your required sample size. So when exactly do we use such margin of errors? Like, I'll give you an example so that people can contextualize like what's happening. So for a margin of error, we usually use a margin of error that is really, really tiny. We don't allow any room for mistakes in medical and legal audits, right? So we want little to no mistakes. So our required sample size would be very big here. It's 9,000. So usually for medical research papers, we don't really, you need a good sample size because as I mentioned earlier, like, we also don't want the research to be very costly and etc. It would be too hard as well. So you can use a margin of error that is only 5%, and you can see, as you can see here, there's only 385 sample size. And for pilot studies, you can use a 10% margin of error because it's just a pilot study. So it's not yet the actual research paper. So to end this, I guess, to end this presentation, I have to say that you always round up the number. So sometimes when you go to calculate in Cochrane, or as I mentioned, Yameen's, or like an actual like calculator, usually they give you numbers like 38.4. So you can't really take a person and say, oh, you're the 0.4. So you just round it up. So 35. So I need 35 sample sizes. I need 35 sample size, yeah. And then oversample for attrition. So what does this mean? So usually when you do a research, it's not, the people will not always like continue with you, right? Some people will get bored. Some people will not finish let's say a research survey, or like they won't continue. So you have to put that in the expectation. So usually say that you have a sample size, which is 385, usually add 20% to that. Let's say make it 420, just in case you allow yourself to include those who might drop out of the studies, right? Use validated tools. The third point, there's an actual tool which is more accurate, like G-Power. It's usually the gold standard for like actual heavyweight researches. And define your boundaries. As I've mentioned earlier, like we should know the population. Like it would be better if you know your actual population, because it's easier for your calculation, and it's easier to as they tell you, to always define your population before you start the research. So you have to know exactly who you're doing research on, so that you can prevent any kind of errors later on. So yeah, that's it. I'm done with the presentation. Thank you so much for listening. Does anyone have questions? And unfortunately, I actually prepared calculations as well, so that I could actually clear it out. But as I mentioned, like my laptop is dead, so I apologize. Sorry, so sorry to everyone. So yeah, does anyone have any question for further clarification?
Thank you so much, Dr. Lujane. And I think it's important to understand the concept and how to do the calculation. As you said, there are different tools. So thank you for sharing.
Yes, thank you
If
so
no
much, Dr. Nader.
You're welcome. If no more questions, we can go ahead to the next topic. Before that, I want to share with you, there is a link in the chat that's a list of open or new residency program that they have maybe some open spots. If you are here in the US and you are ready, you can apply, or you can contact them and see if you will be eligible, and I wish you all the best. So we can move on to the next topic.
All right. Thank you so much, Dr. Nader, and thank you, Dr. Lujane, for that presentation. I guess, can everybody hear me, first of all?
Yes.
Okay. So I guess my presentation is kind of going to be a follow-up of Dr. Lujane's. It's important to understand how we can collect our data or our sample size, but how can we input that? So this is going to be basically the content of my presentation. Let me just go ahead and share that. I'm not sure if everyone can see my presentation. All right. So basically, today I'll be talking about mastering statistics. There are some things that we need to check when we're doing research after we gather our data. We need to check for the normality, and we need to do descriptive analysis. So this is basically what we're going to be talking about. Section 1 is going to talk about the normality. So why and how we basically validate the Gaussian assumption. So basically, in order for us to, before we press any single button in SPSS, we have to actually think of something. We have to think of the normality. So most of the powerful tools that we use, like for example, the t-tests and ANOVA, they have a contract. They tell you that I will give you accurate information, but your data needs to be normal. So what does a normal data look like? The distribution has to look somewhat of the sort. It has to follow a bell curve. So this is basically how it's supposed to look like. If our data is skewed, the contract is void. So basically, these parametric tests that we use are not going to give you accurate information. It's going to lead to biased results and false significances. So this is why we need to check the normality, and it's a very important step that we cannot skip. So how do we exactly do that? But before that, we need to understand that having a bell curve shape is important because we need to, this is how we decide if we're allowed to use the standard math or if we need to do something else. So in SPSS, we basically, I'm so sorry, I don't actually have the thing on my laptop, so I'm just gonna use this picture. Hopefully this will be sufficient enough to explain to you what we do. So we're gonna go to analyze, and then we're gonna press on descriptive statistics. Afterwards, we are going to go to explore. So it's a very important step wherein we press on explore. And then afterwards, we are basically going to take our data and we're going to move it to the dependent list, right? So we're going to move, like, for example, say that your data is basically systolic pressure or heart rate or whatever. We're going to move it into the dependent list. And then afterwards, we need to click on plots. And afterwards, normality plots with tests. So if we forget that box, we basically might be flying blind if we don't do this. So it's really, really important that we do this. This forces the SPSS to run the Shapiro-Wilk diagnostic, which is basically the gold standard for normality. So let's see how that looks like. So when you run that test, you're going to see a table called the Shapiro-Wilk. I want you to look at this. So basically the p-value. What is the p-value? This is a really important thing to look at when we're trying to interpret this test. So we're going to see this and we're going to think of the p-value as an alarm. So it's basically an alarm system for like weirdness, right? So here's the thing. What we want to see is that if our alarm is silent and it's basically the data means that the data is normal. If our alarm is ringing, if the p-value is less than 0.05, it means that the data is not normal. So this is how we interpret this. Once we input our data and everything, we're going to go see this table and we interpret it using the p-value, which, as I said, is kind of like a weirdness scale. If our scale is more than 0.05, that's great. If it's less than that, then that's not good. That means our data is not normal and everything is going to be so messed up moving forward. So this is kind of checking your foundation. If your foundation is not stable from now, you're going to have a really, really shaky research going forward. So the visual proof. So while the p-value gives us the yes or the no, we also need to visually look at it. So we don't really trust numbers alone. We always verify them with our eyes, especially using the Q-to-Q plot. So I don't know if this is, if you guys can see this, I don't know why it's a little weird here, but we basically have a line right here. This basically represents a perfect normal world wherein your data perfectly aligns on this 45-degree angle line. But however, if your data points hug that line, that's a good sign, right? So not only are we trusting the numbers, but we're trusting the visual diagnostics for this one. So the diagonal line represents a perfect normal distribution. If the dots hug the line, then your data is clean. If they are curved away like a snake, I don't know if you could see here, they're basically going to be skewed. So you have outliers that are biasing your results. So it usually means that you have a few extreme outliers pulling everyone else's off track, basically. So this is how we can also double check our data and how it's basically aligned. So we also have another thing to look at, which is basically the mean and the median. So we want to talk about average here. We have two main ways to find the middle, the mean and the median. So we call the mean a diva because she's incredibly sensitive to every single score. So if you're measuring hospital stay times and one patient stays for 200 days, while, for example, everyone else stays for 3 days, the mean will skyrocket. So it's mathematically correct, but it's a lie because it doesn't represent the typical patient. So we can think of the mean as calculated as the sum of all scores divided by n. It is sensitive to every single value. One billionaire makes everybody looks rich, and this is the formula that she follows. We have another thing to look at, which is the median. So this is the person standing exactly in the center of the line. It doesn't matter. She will be in the middle. And the median is basically a robust. It doesn't care about the 200-day outliers that one patient stayed. So if your normality alarm rang, as we said, if it's less than 0.05, then you're going to go for who? You're going to go for the median. She's the only one who's actually honest. So the median is the only honest way to describe your group. So by definition, the literal middle person on the line, robust and resistant to extreme values. If your data failed normality, then we report to the median. So if the mean tells us where the middle is, the standard deviation tells us how much the group actually differs from each other. Here we can see that it represents the average spread or distance of subjects from the mean. It measures the trustworthiness of your average, basically. A low standard deviation, it means that you're highly consistent and most of your subjects are nearly identical. A high standard deviation means high diversity. So your group is incredibly varied. So your robust check use IQR for non-normal data. So if, for example, the average recovery time is 5 days, but your standard deviation is 10 days, that average is almost meaningless because the patients were all over the map. So the standard deviation tells you how much you should trust your average. So this is also an important thing to look at when we're doing our study. So here we're going to look at the distribution personality, the skewness, and kurtosis. I'm so sorry. I really don't know why this is not clear, but I guess I'm just going to try to explain it. So the lean or skewness, it measures the symmetry, right? So we want to measure the symmetry. A positive skew has a tail pointing right. A negative skew has a tail pointing to the left. I don't know if you could see this. It's pointing to the right, and this one is pointing to the left. So this is basically how it's going to look like. So we're going to think of it this way. Does the data have a tail? If my tail is going to the right, that means I have a positive skew. If my data is going to the left, it means I have a negative one. The peak, or something like this, measures the peakness. So high kurtosis means everyone is clumped in the middle, but with heavy tails. So all of this actually really helps us not only measure our data via numbers, but also visually. It's really important to understand all of these variables that we just talked about in order for us to make sure that our foundation, once again, is not shaky. And we make sure that we can have a good foundation for our research. So we don't get lost at the end. So accurate statistics ensure honest science. Always check before you report. And with that, I end my presentation. Thank you so much for listening. If anyone has any questions, please do not hesitate to let me know. And I guess ask yourself the question of, did they check the normality of the data before they did anything? And include yourself in the day so that you can ensure that your data is always correct. And thank you so much. If anyone has any questions or anything they'd like to add, please go ahead.
Oh my God, thank you so much for that presentation. Actually, it's such a simple way of looking at it. Like, I actually studied this for like a long, long time, and that was such a simple take. I don't know, I kept on repeating it, and that was such a beautiful and nice summary of what exactly is going on. So yeah, it makes my hours look crazy.
Thank you
So
so
thank you
much.
so much. It's such a beautiful way to actually explain it. And yeah, and I needed that refresher as well. It's a topic that I keep on forgetting for some reason. So yeah.
Thank you so much, Dr. Lujane. I'm really glad. This was really the point of the presentation, to make it look simple, I guess, because we always need to, sometimes especially in research, we get so lost in the specifics of it and how crazy it is. So we kind of need to take a step back and look at the bigger picture. So thank you. I'm glad that transcended.
Yes, I have like a suggestion like for the people. I don't know. I feel like SPSS may be controversial. I would like to hear what people think, like my fellow researchers. What do you guys think of SPSS kind of being outdated, and maybe Jamovi is a an application that is maybe a bit less complex than SPSS. Has anyone tried it?
I think someone answered in the comment is that they still rely on SPSS, but the interface maybe isn't the best, but once you get used to it, you find it easy.
Oh, okay, okay. Thank you. Thank you so much for sharing. Yeah, I wanted to hear like what people thought about the recent new applications and like is SPSS still the best thing? Because I was thinking like to leave SPSS behind, but would it still be like I don't know, I feel like I'm missing out. So I feel like I should go back to SPSS. So yeah. Thank you so much, Dr. Omar.
It's hello, how are you, everyone? The problem is that some journals, if you use an application or program that's not recognized, they will be questioning the program because there are like small details when it comes to small numbers. SPSS really care about that. And these little differences sometimes make it problematic for reviewers. But when you mention the methods that use the SPSS, let's say version number 20 something, they feel more comfortable with it. So maybe that's a major reason for me.
Thank you so much for telling me this. Like this is why I ask. Thank you so much. I actually did not know about this. That like some journals actually like look at those. Because I was thinking of leaving it behind, and the last research I did was on SPSS. But I was thinking of, halas, like I'm over it. So thank you so much for telling me. Thank you. So to my fellow researchers, as you guys heard, Dr. Omar, thank you, thank you. Hello. Okay, so I think we're going to go to the next part if nobody has any questions for Dr. Omar. So yeah, anyone who has any project updates?
Um, I'm leading the project number 71. It's about the patient's satisfactory reaction and opinions about the use of telemedicine. It has been paused for a very long time, unfortunately, and I think it's going to need an update of screening and search and everything. The problem is that we using, I think, Rayan application, and I don't think it's a very good one, to be honest. So I'm asking if any member has access to Confidence, as it's more accurate and easier to use and more accurate. Yeah, that's my question, is if anyone has access to Confidence, because I think having access to Confidence and be shared by the members of the fellowship will make work way easier. I used Confidence and used Ryan and used the old classical way using Excel, and I think Confidence by far is the easiest. Unfortunately, it's paid, not like the others. So yeah, I'm asking if anyone has access to Confidence.
Unfortunately, like Covidence has been very strict with their subscription-based thing. I managed to connect with University of Petrosia for some reason, but they closed it just recently. So if anyone can share with us, so yeah, that would be nice. Dr. Omar, do you not think that maybe the paid version of Rayan would be helpful or good, or do you think like it's still not as good as Covidence?
I don't remember I used the premium version of the Rayyan, but it could be better. But from what I've seen from the features they had in Rayyan, even the premium version, I don't think it is as accurate as the Confidence, especially that there are some features common between the version and the the premium version and normal version of Rayyan. And these features, they weren't really good enough even with the simple version. I think it's not really accurate. Yeah, they improved the interface and everything, but Confidence is superior. I can say superior. It's so easy to rely on it. Yeah, that's what I think. I have been working on it for a very long time now. But I don't
Thank
have
you
access to
again.
it. Yeah, but I'm working
Thank
with
you
groups that
again.
have access to it. Yeah, you're welcome.
Thank you again. Because then again, I was gonna do the same thing for Confidence. I was like, it doesn't have AI features and like it's kind of slower. I'm like, I'm going to leave it and I'm gonna go to Rayyan. And thank you so much for sharing. So yeah,
Confidence do have AI features actually. Maybe the one giving me access have something extra in their subscription. I don't know, but it does have AI. You can activate it. It helps a lot actually.
really, because the my Confidence already, as I told you, like it shut down. Um,
Oh,
uh,
sorry to hear
so
that.
like when you get like when you link with the people who have Confidence, like is it like a close group or how do we access them? May I ask?
Yeah, they actually have like a close group of researchers. It's very huge, actually, like maybe hundreds of members. I don't know what type of subscription they have actually, because they have more than 200 projects, ongoing projects now. Maybe they finished half of them, and they use Covenants for all these 230 plus project, and maybe a lot of members, more than 200 members, maybe 400 members, and they're all using Confidence. They have accounts there. They have access to it.
All right. All right. Thank you so much for
Yeah,
sharing.
you're very welcome.
Is Dr. Nader still with us? Hello.
Hello. Yeah, I'm
Hello,
back.
Dr. Nader. In
Hello.
regards to my, I'm also like a project leader of project for the fibromyalgia app, and I just wanted to ask you, if
Mhm.
there's a duplicate in apps in terms that both Apple and Android has the same app, do we exclude it or do we consider it as one app or do we still write it as is? How do we deal with the duplication in the applications?
So it depends on how you want to present it. Usually you will combine them as one app in your analysis and let's say features and whatever data you want to collect. If you want to compare the apps in Google Store versus apps in Apple Store as number wise, you can put them separate, like the same app in both sites. For example, in a
Okay.
graph, you can say there are 25 in Apple Store versus 73 in Google Store. And you will have a couple of them in both, if that makes sense.
Okay, thank you so much.
When you
Yes, that
are
makes
analyzing,
absolute
yeah,
sense.
yeah,
Yes.
thank you.
Dr. Nader, I noticed that most of these apps, even though it's free on at least on Apple, even though it's free on the initial downloading of the app, most of them actually require a monthly or yearly subscription. Like, do you think like this is maybe like a point that we can talk about in the abstract,
Oh,
or
sure, yeah.
maybe irrelevant? Okay, okay,
Yeah. You can
okay,
talk about it, and yeah.
okay. Okay. Last point, I promise.
Yeah, that's okay.
So there is this application, some of them, because I think so for chronic illnesses, it sometimes can go under the term of spoon or spoonies for chronic
Mhm.
illnesses. Um, some of the applications were dating apps or just food apps. Do we completely remove them or do we still acknowledge it as these are the 200 applications that we've screened, although we excluded it, or do we completely remove it from the data?
So you can mention them as this is the totally found, and then we remove this because they don't meet the criteria for inclusion, and
Okay, okay.
the numbers, let's say. whatever, 40
Okay, thank you,
credits.
thank you. Thank you
You're
so much,
welcome.
thank you so much.
And I think you are targeting the conference as abstract. Is that correct? Or you are trying to write a paper?
Yes, as of now, it's still an abstract.
Okay, because there is a conference here in Michigan. The deadline is June 1st.
Yes, I'm aware. Thank you.
That's all right. Yeah, I just want to make sure. Good. Any other updates? Anything you are working on, guys, that you want to share? How far you are or what's going on? Or any questions, updates, ideas?
Hello, can you hear me?
Yes, go ahead, please.
Yes, I do have an update about a project that I was leading with my incredible teammates, and Alhamdulillah, we got the acceptance for it and everything, and we have arranged for the conference, and we already got our ticket. So, inshallah, one of our incredible teammates is going to be presenting it at the conference, and we're so excited for that. So, honestly, I just want to voice out how much of an amazing experience it was, really. And I felt like we all gained from each other while we were doing the project. So we're so excited and we cannot wait to see what happens at the conference and how our amazing doctors are going to present it. So yeah, I guess this is a quick update of Project 4, which was the project I was leading.
That's good. Which conference you are going to, or the presenter? Which conference?
I'm so sorry. Can you hear me?
Yes, I can. Congratulations. And which conference you said?
Thank you so much. Um, basically it was, I'm so sorry. 1 minute, please.
Sure. I just asked because we are trying to target different conferences, and sometimes I lose track. So I need
Yes,
your help.
sorry, yes, it was basically at the Regent's Park, it's the Royal College of Physicians, Medicine 2026. We already booked that and everything. So
Excellent.
yeah. We will have a member there in person. Thank you so much.
Congrats. Yeah. I'm very glad that you are working as teams and you are learning from each other. And I think this is what the goal is, to learn from each other. Every one of you is unique and you have some skills, and it's nice to see that you are sharing your skills and teaching each other. Any other updates of new ideas for any of the conferences or manuscripts or mobile applications?
Yeah, Dr. Nader, I just wanted to just say thank you again, for making that possible, to allow us to link with other people and to be able to publish together, which is truly amazing. So it's really amazing what you're doing. So thank you so much. Really grateful.
You're welcome. You are doing the whole work, hard work. So I want to share with you an idea that I was thinking, and I shared this idea in the past, I think last year. So maybe I'll show you in a simple. I'm going to share the screen and I'll walk you through the idea. So basically, here's a recorder. So it has different version, but basically I created this simple idea of mobile app that IMGs or anyone who is going through an interview process to be able to just record the answers. Let's say they ask you, tell me more about yourself. So you just click here and then you talk about yourself and then stop. And then it will show you how many seconds you spent, how many words, and your speed maybe. You want to speak louder or faster or so on. And you can save or download that. The next step, which is I want to help analyze this into making it more user-friendly and more feedback. So the recorded file, instead of just downloading it, saving it as a voice or sound file, I want to send that file for analysis. I can send it as a sound, or I can transcribe it into a text. So the next step is to make that as a text. So what we did is we created this one. Basically, an interview preparation file or tool. And here the so it has the home link and the setting, the progress, and some resources. So you start with enabling your microphone. Then there are starting point where you will do the same. So here you will hit record or tap for microphone to start recording. And it's supposed to bring whatever you say. I'm not sure if it's gonna work for you here or not, but basically you can answer the question here and talk about yourself, your background, and so on. When you hit save, it will, oh, it worked. So it will save your answers here, and it will tell you how many words and your speed and so on. So the next step is to use AI feedback. In that sense, you can type more, or you can add more recording here, and then you ask the AI, and it's connected with an AI tool that will transcribe and read the answer, evaluate it, check for structure, and give you a feedback. And here's a 4-point or score that you want to look at. But basically, it will analyze what the strengths, your knowledge, your awareness of the answer or the question, and getting some experience. But it will give you also room for improvement. And then it will give you some detailed feedback along with areas for improvement where you want to shine or you want to add more specific things to your answer. And here the model answer, how it's supposed to be, and you can modify this as you go along. So basically, this is the second version, which is to help the candidate prepare for common questions. And these questions can be divided by specialty, like internal medicine, family medicine, and so on. And you can go along. And you can get the report about how many questions you have and the score you got for these questions, and you can repeat the same practice or questions again. The different resources for the match. So if you want to get more interviews tips, it will be here. The method of start also, how to answer a question, like the behavior, situation, task, action, and results, how you walk or take the interviewer with you, like step by step, talking about your own experience and what you learn and how you will be an asset to their program. Some of the tips here. So this is the version that we are working on. The third part I'm thinking about is we are trying to use the camera, and I don't think I'll be able to show you while I'm using this camera for this meeting, but the idea is use the AI to analyze your expression, your face, your body, while you are answering the question. So if your eyes are not not looking to the camera, it will highlight that. So most of the time when you are in an interview, the person asking you will be in the screen down, and you will be looking down the screen while you are talking. And sometimes on the other side, they see that you are looking down, you are not looking at their eyes. So the trick is to look at the camera, not the person, while you are answering the question. And the app will analyze your sitting position. So if you are closer to the camera or you are leaning backwards, also this will be analyzed. Gonna share. So this is an image about how the app will look at you. You will sit down, you look at the camera, and then answer question. And it will analyze your eye contact with the camera, your position. Is it the level where it's standard straight position, or are you leaning forward? Are you leaning backwards, and so on? So this is the next step we will be working on. So I might need some beta tester from you guys. If anyone is interested, please send me an email or message, WhatsApp, so that when we have some of this in process or in action, we'll ask you to test it and see if it's helpful, if there are any bugs or errors that need to be fixed. So any questions? Thank you.
I have a question just based on like the app part. Does this need coding?
I'm using AI to code for me, but I have some knowledge of some coding, so I try to tweak it here and there. But I already developed most of it using the AI so far.
Oh, mashallah. Uh, um, wait, yeah, because I'm sorry, like on the app of the fibromyalgia, I was thinking, I noticed that most of the apps, so when the people have their attacks of the fibro fog, or like when they're having the illnesses at the acute flare, I noticed that these apps tend to ask so many questions, which can be very overwhelming. So even as for me, like I wasn't even someone who had like an attack. I felt like I was answering way too many questions, and I also thought of maybe a voice command that you can like say what you're experiencing and let AI transcribe that, instead of actually like you keep on you keep on answering it while you're already not in a good mood. So I was thinking maybe we can develop that, but I had no idea how. So maybe like your skills and knowledge of app development, I can learn something from it.
Sure, I think we can use the same concept. So basically, let the user or the patient, when they are during the attack, they can just talk to the app, open the app, open the mic, and then tell what they have, and then this will be transcribed the same way. Go to the AI and divide that into sections. Let's say, do you have pain? Instead of yes, answering yes, no, then the patient will say, I have this headache, I have this, whatever. Then the AI will answer that question, yes, I have pain. What's the location? It's the head, whatever. So it's gonna analyze, divide that, and put it into a context as far as the questions that you have, like or the questionnaire. It's a good idea. But yeah, thank you.
Doctor, may I ask, is this ChatGPT or Gemini, or is it a particular other AI like Manus?
So I use all of them, and I think I started with Cloud, building the simple idea. So the one I showed you, just the recording, I used Canva just to start with. Then I used different ones to manipulate that. And the last one I used is Cloud. But even with Cloud, I came across some issues. So to improve it, I used, so I get the code file, I send it to, let's say, Gemini, ask what's the problem with this file, and then what's the improvement that I can add to it. And sometimes it fixes some problems, but it will add new problems for me. So I have to
Okay.
figure it out. Yeah.
Okay. So it's trial and error.
Yes, it's just basically trial. So I have the final, what I can say, the app working, and I asked my family member to help me use a device like the phone, iPhone, Android phone, or tablet, and every one of them I have issues. So I have to figure out how to make the phone, the accessing the mic, and then the mic transcribing the data. And in some instance, we need a key to access the AI so that the mic can transcribe the data for you. It's kind of stepwise, so I have to figure it out which device and how to the browser, and so it's still working in progress. But eventually, I will need some testing, as I did with my family, to look at if the best to use it in the computer like a screen, or if I want to make it as a mobile, we may test it in an iPhone and Android device or tablet and see if there are issues, how to handle these issues. And eventually we can improve to the camera and so on. But yeah, go ahead.
Thank you so much. No, thank you. A beautiful way. How do you have the time, Dr. Nader?
No, just playing around.
Yeah, mashallah. Thank you so much, as always.
Thank you. Any other updates, guys, or any questions, anything that you want to share, want to ask, want to add?
Hello, Dr. Nadir, how are you?
Hello, Dr. Fatma, go ahead. Alhamdulillah, how are you?
Good, alhamdulillah. Yeah, I have a suggestion. If we like all people who will be applying this September, so if we can connect with each other and we can have guide from someone is already matched or applied for the last years. So if any possibility of that, I will like that for people who will apply this September.
That's a great idea. So why don't you create a WhatsApp group and invite?
I created already.
And the big group, WhatsApp group, I invite them to join your small WhatsApp group and see. And then in the app, we have the fellowship app, you will find a list of those who matched this year or previous years. And you can try to contact them and see who will be available to give you feedback or advice or share. And I think some of them are very helpful, like they try to do mock interviews and so on. So yeah, thank you.
Yes, thank you. I created the WhatsApp group already. And last time, I think about some people asked me to add them. I added about one or two people. Then one of them left. And the third one, I tried to apply to add, but I can't apply her. I think her. So I created the group already. Thank you for
Sounds
everything you
good.
are doing for us. Yeah, thank you.
So any one of you interested in applying this year, maybe you can contact Dr. Fatma. You want to share your phone in the chat here? Maybe someone will be in contact with you.
Yeah. Yes, I will.
Thank you.
Okay.
Any other questions? Any other comments, ideas? Anything that we need to address, improve? So, Dr. Lujane, there is I think a link to also fibromyalgia app in the file. So if you want to look at that with your group and see if there are any issues or need improvement, that would be also an idea. Thank you.
Yes, of course. May I ask, so this file can only open in an Android, or can it open in a laptop?
I think it's a web-based, so any.
Oh, okay.
Yeah.
Thank you. Will
You're
do.
welcome. Sure. All right. If no more questions, I'd like to thank you all for joining this meeting, and I'd like to thank all the presenters, the organizer for this meeting. Thank you so much for wonderful presentations. We learned a lot from you guys. And also I'd like to thank those who will come and watch the meeting or the recording in the future. Thank you in advance. Have a wonderful day or night. See you next week. If you have any questions, please email me or call, text, or WhatsApp. We'll see you next week. Assalamu alaikum. Fi amatillah.
Assalamu alaikum. Thank you, Dr. Nader, for everything you are
Alaikum.
doing, and thanks for the presenters. Have a great one.
You too. Have a wonderful one. Fi amatillah.